which are the immature form of the erythrocyte in the bone marrow. Okay? You guys are going to see this slide a lot when I'm around because this is my wheelhouse, hematology, oncology, so you got to know this, okay? So make sure that you remember what are your myeloid-derived cells, what are your lymphoid-derived cells. Remember that the blast cell is the most immature after the progenitor, right? So you have the hematopoetic stem cell, then you have the common progenitor cell, which is either myeloid or lymphoid, and then subsequently you have your blasts that are lineage specific, right? So each lineage is going to have a blast cell associated with it. Megakaryoblast, erythroblast, myeloblast, and lymphoblast. Within the myeloblast line, you're going to have all of your granulocytes plus your monocyte, and then you have your megakaryocytic line and your erythroid line. What's wrong, Sarah?
It's just that line. It scared me. I thought it was a bee or something. It's huge. It's huge. It just scared me.
It's the blood. Okay. So remember back to the slide that I showed earlier on when we talked about platelets, right? And we talked about TPO, we talked about EPO, we talked about granulocyte and granulocyte, macrocyte, or macrophage monocyte stimulating factor. So those are the factors that I want you guys to look at because these are the ones that we have made man-made recombinant forms of: TPO, EPO, GM, GCSF, and GCSF. All right, so you can see where they're actually active, right? So GM GCSF is going to stimulate here at the common myeloid progenitor and stimulate all of this stuff. Whereas GCSF is specifically really stimulating the myeloid-specific lineage, like your granulocytes and your monocytes, but not so much your erythrocyte and your megakaryocytes. So we're going to talk about these and when they're used in practice. Most of the time, unless you're working with patients that have chronic anemia or chronic disease due to chronic renal failure, that's probably the biggest population that we see erythropoietin used in. Otherwise, as far as using thrombopoietin and granulocyte stimulating factor, mostly we're using those in patients with some kind of hematologic abnormality, that they're not producing enough cells. All right. So we can use growth factors, we said, to stimulate red blood cells, myeloid cells, specifically neutrophils, and platelets. All right. So erythropoietin, Stephanie told us, is a glycoprotein produced by kidney. Very good. It is helpful in helping stimulate the erythroid line. So what's a reticulocyte?
It's the blood cell line before it becomes an erythrocyte.
Immature. Okay, so how do we tell the difference between a reticulocyte and an erythrocyte?
Reticulocyte has some leftover RNA.
Okay, so might have some actual little like speckling to it. What else?
Mitochondria.
So the nucleus, let's like just get the preconceived notion that a reticulocyte has a nucleus in it. So a reticulocyte has to extrude, the erythrocyte that is immature has to extrude its nucleus and release into the peripheral blood in order to be called a reticulocyte. If it still has a nucleus, it's a nucleated red cell or orthochromatic erythrocyte. Okay? So if it's in circulation and it doesn't have a nucleus, we're saying it's a reticulocyte. The reticulocyte tends to have different coloring, right, than an erythrocyte has. An erythrocyte has that deep pinkish red coloring to it when we stain it, whereas a reticulocyte kind of has a lighter bluish purplish color and doesn't really have, it's not as mature looking, like it doesn't have the characteristic invagination that an erythrocyte has when you look at it in a one-dimensional view, right? So we can give erythropoietin in a recombinant form using two different options for agents, erythropoietin or darbepoetin. Darbepoetin was made after erythropoietin, and the half-life is longer, so we have to give it less frequently than we give erythropoietin, which is a benefit for the patients with less injections, and it acts for longer. All right, so do you think EPO would be effective in acute bleeding, Stanley?
Do I think EPO would be effective?
EPO, right there, right now.
No.
Why?
2-year-old.
Why? Right, it takes too long. So
Yeah.
how long do you think the process is to give the erythropoietin, for the erythropoietin to then stimulate the red cell production in the bone marrow, and then for the bone marrow to mature and turn out erythrocytes into the peripheral blood? How long do you think that takes?
A while.
At least a week, right? If not longer, right? But it takes a while for that process to actually occur. So if someone's acutely bleeding, you can give them all the erythropoietin in the world. It's not going to do anything. So if someone's acutely bleeding, what do we need to give them?
Blood.
Heart red cell.
Blood. And then figure out where the bleeding is and stop it, right? Yes? You have a question, Mark? Oh, no. Okay. All right. So what do we use this for then? So we can use it for patients with anemia of chronic disease, renal failure, AIDS patients. We can use it for cancer patients. There is some hesitancy about using it in patients with solid malignancy because erythropoietin can be, or has been shown in some small studies, especially in breast cancer patients, that it actually can cause promotion of tumor cells. And so there's some hesitancy that this has been proven, and then there's been some studies that have disproven it, but there's some controversial question about whether or not erythropoietin, as it stimulates our erythrocytes, also may have some stimulatory effect on tumor cells itself. So where it is FDA approved is in patients that are on chemotherapy longstanding that do not have hematologic or hematopoetic malignancy like AML, ALL. We do, however, use it off-label in a lot of those patients. But the question is whether or not, if you're using it on a patient with cancer in the bone marrow, could you also be potentially stimulating cancer cells to be growing there as well? It's kind of a risk-benefit because if you have a patient that's transfusion dependent, there's a lot of risks associated with frequent blood transfusions. So can you think of any risks that would be associated with getting a blood transfusion every week or every other week? Infection. Okay, so infection, actually the risk of blood transfusions now, in this day and age, the risk of infection is very low because the blood is screened well. Are you talking about infection from having access?
Yeah.
So if you have like a Lyme, certainly that could be a risk of infection, okay? So antibody formation, generally we don't form autoantibodies to blood as long as it's the right type, right? So we do to platelets, but generally we don't form autoantibodies to blood that can't be screened for. So before we give anybody blood anytime, we type in screen and cross them, right? And so we check for any antibodies that could have developed, you know, over time, and then we give them the appropriate blood, right, based off of that. Versus platelets, there really is no like cross-matching. So we give platelets, and because it's oftentimes pooled or single donor platelets that are coming from another person, you can develop more antibodies to that for sure.
Are you like less stimulated to make your own?
No. So if you're getting transfusions, there is no change in how your bone marrow is stimulated to make red blood cells.
Iron overload?
Yes. What'd you say?
Iron overload?
Iron overload.
Iron.
There is 250 milligrams of iron in every 1 unit of blood. Okay, that is a lot of iron. Okay, in 1 transfusion of blood. So patients that are getting frequent transfusions are at risk for iron overload. That's deposition of iron, excess iron that can't be utilized by the body, depositing in the heart, the liver, the lungs, all these tissues that does not allow the tissues to function normally. Okay? So this is a good reason to use erythropoietin to stimulate the bone marrow to make its own red blood cells rather than constantly needing to be using transfusions, if the bone marrow has the capacity to do so, right? So I'm not going to stimulate somebody's bone marrow that has aplastic anemia constantly that doesn't have any erythroid precursors in the bone marrow. It's a waste of time, right? There has to be something to stimulate. But if there's some other reason, like they don't make erythropoietin because they have chronic kidney disease, replacing the erythropoietin is a good idea, right? The bone marrow works normally. So if we can just stimulate it to do its job, that'd be great, okay? So it increases not only the proliferation, but the division, maturation, and then release of reticulocytes into circulation. Also helps with hemoglobin synthesis. Now remember, it does all of this process, right, of actually increasing the bone marrow's production, differentiation, proliferation, and synthesis of red cells requires some certain building blocks that are really important to be able to have maturation of the cells. So up here it says that iron is one of those things, right? Which makes sense because iron is part of the molecule, right? Where we have a red cell, we have heme, we have globin, and our iron is part of that, right? Centrally. Okay, so that's important. What else is important?
Folate and vitamin
Folate and vitamin B12, right? So all of those have to be not deficient for this process to work well. So if you give erythropoietin to a patient that's iron deficient, it's not going to work, right? So the patient has to have no other deficiencies, for erythropoietin to work, okay? No other deficiencies, okay? So iron has to be replaced. So check the iron stores, make sure the patient is not iron deficient before you give erythropoietin, okay? All right, so you can give this IV or subcutaneously, you can give this at dialysis. It is weight-based, so remember the erythropoietin you're giving multiple times a week, and the darbepoetin has about twice as long of a half-life, so you can actually give it on a less frequent basis and give it just once a week, which is much more convenient. So there is some contraindication. So using it in a patient with a hemoglobin of greater than 11 or 12. Bradley, why do you think that's a contraindication? So 11 to 12 is anemic, right?
Oh, yeah.
So why is that a contraindication?
Because like it really helps out that
Okay, so it really, really helps out. And if it really, really helps out, what could happen?
you can have overproduction.
Okay, and then what?
Then you have too much erythropoietin, then you become hyper.
Yes, okay, so if you overstimulate the bone marrow, if you have someone that's kind of borderline anemic, right, you stimulate their bone marrow with erythropoietin to make more red cells, and their hemoglobin goes above normal, you can cause hyperviscosity, right? And hyperviscosity, or too many red cells, can lead to bad things, right? Like clots, like strokes, right? So there has been some literature and a black box warning actually released to say using erythropoietin in a patient with a hemoglobin above, some say 11, some say 12, is actually a contraindication, and it increases the risk of stroke significantly. Okay, so that's really, really important. So before you just, especially in a patient you're dosing this 3 times a week, you need to know what their hemoglobin level is, right? So you have to at least intermittently check their hemoglobin and make sure that they're not really riding that line, because they may not need the erythropoietin anymore, okay? Side effects, and also I mentioned we don't use it in myeloid malignancies and uncontrolled hypertension for the same reason. So side effects can be associated with some neurologic toxicity, heart failure, headache, and as I mentioned, there has been some data to support that they have been associated with increased thrombosis risk, so we really want to be mindful of making sure we know what the hemoglobin is really before every dose. All right, so when should we expect improvement of the hematocrit, Jennifer? All right, so we give administration of the erythropoietin, right? And we said it takes at least a week, if not longer, just rubbing it in your face, at least a week, if not longer, to start producing more red cells. So when are we going to see an impact on the hematocrit? Enough.
More than a week.
So the life of a red blood cell is 120 days, 4 months, okay? So if you had to estimate when we're actually going to see a change in the hematocrit. So weeks, right? So 4 to 6 weeks generally, okay? So how do we know if it's actually working? If we don't see a result in 4 to 6 weeks, what could help us figure out if it's actually working? stumped you all.
Oh.
Yes! Very good! High five! Check reticulocytes.
Oh,
Absolutely. So what should the reticulocytes do?
The reticulocytes are then become red blood cells.
Good. So what should we see the reticulocytes
That's what
do?
they-
Excellent. So we should see that the reticulocyte count is increasing in the peripheral blood within 1 week. Okay? Within 1 week of supplementing any of this, iron, B12, folate, it's a great measure to tell us what we're doing is working. The reticulocyte count is increasing. If we gave EPO and the reticulocyte count didn't increase, we should be thinking what? Are they iron deficient, folate deficient, B12 deficient? We check all those, they're not. Bone marrow problem. Boom, yes, very good. So you see how we're thinking about this. Okay, very good. So is there a problem with the bone marrow actually not producing red cells? Why? Right, is there some weird thing going on? Does the patient have some kind of cancer? Does the patient have aplastic anemia where their bone marrow can't make red cells? What's going on? Good. All right, so make sure all of these are replaced, at least check levels if you're not sure. They're all really critical in development. So remember this little diagram here from pathophysiology. Remind yourself the importance of iron in all of this. So this is just one molecule, right? Iron is central to it. You have your hemoglobin change. All right, so iron is important. Without the synthesis of the synthesis of hemoglobin is doomed. So most of the iron we have stored comes from the food. It's absorbed in the small intestine. Excess iron is stored in the liver as good. So who's at risk for iron deficiency?
Women?
Why?
Because of menstrual cycle.
Menstruation. Good. Who else?
Malnourished children.
Okay, so anyone that's malnourished.
What about babies? Like babies that did not get enough iron from like breast milk or something?
Okay, so babies generally that are, not babies that are breastfed unless their mom has
the
iron
other way.
deficiency,
Babies
but
that
babies that
aren't.
are given cow's milk too early on, right, can develop microscopic colitis from the protein in the cow's milk. And also calcium in cow's milk decreases absorption of iron in the gut. And so children, most common cause of iron deficiency in children is actually cow's milk under the age of 2. Okay, so what do? So we need to make sure that we know what are the risk factors for iron deficiency, and then we need to know what to do about it. So we need to figure out, is the source of the iron deficiency loss of blood, right? So in a female, female between the ages of probably like 20 and 40, the most common cause of iron deficiency is probably menstrual irregularities. Once we get postmenopausal, and including men in that population, the most common cause of iron deficiency is GI losses. Right? So that's where we screen for colon cancer. And then certainly there's many different reasons in between them. This is just a little algorithm, so you guys are going to start seeing algorithms in medicine. They're not perfect, right? They're just used as a guide. So if this, then that. If that, then this. That's, your patient's not necessarily going to fit into the algorithm. But this just gives you an idea of saying, like, okay, if your patient has iron deficiency anemia, how would we know if they have iron deficiency? So we can check labs. So there's specific labs, right? We check a ferritin, the storage form of iron. We check an iron saturation, which is the TIBC over the free iron, right? We check the transferrin and the transferrin saturation to see how much transferrin is actually circulating in the body too. That helps us to differentiate between the cause of iron deficiency, cause of anemia, iron deficiency, anemia of chronic disease, etc. All right. So if your patient meets certain criteria, right? If it's a woman that's not menstruating or a man and they have iron deficiency anemia, we need to work them up for GI losses, right? So they need either endoscopic evaluation of their upper or lower GI tract. Versus if you have a female who's iron deficient and menstruating, it's probably, taking a good history is important. It's probably related to menstrual irregularities. So then what do? We evaluate them, right? But then we replace their iron stores. And I'm going to teach you how to do that. So there's many different forms of iron replacement. The options depend on a lot of things. Oral iron is not very well absorbed, okay? So some people will take oral iron for years and never actually have an increase in their hemoglobin or hematocrit. Has anyone ever taken oral iron for anything? Okay, any comments about it?
I was a kid, so.
So you don't remember?
It makes your poop black.
It makes your poop black. Okay, that's one thing.
Makes you constipated.
So constipating, right? And then how quickly does it work?
Very slow.
Not very quickly, right? So do you want to say something?
For me?
I
No,
think
yeah.
drinking orange juice helps.
Excellent. So any vitamin C compound taken with iron increases the absorption, but not by much. But it does help. Definitely does help because it changes the pH of the gut. So it definitely helps. And actually, there's some iron formulations that are actually with vitamin C that you can buy. To just take it what's already combined with vitamin C, which helps the absorption. Okay, so the ability to actually take pills, right, or take liquid, and then how low is the hemoglobin? So in a patient that has a hemoglobin of less than 8, some people will tell you less than 7, you want to transfuse the patient, especially if it's an acute loss, right, versus a chronic loss. Someone with a chronic blood loss is going to tolerate it much better than someone with an acute blood loss, right? If all of a sudden your hemoglobin went from 15 to 8, you would know it. Versus if I was just slowly drifting down, I might be feeling fatigued, tired, a little short of breath, but you wouldn't notice that sudden change, right? Your body's kind of able to compensate for that over time. But any acute loss or acute drop or a hemoglobin of 7 and 8, you want to transfuse rather than just giving iron therapy orally. As I mentioned, there's a lot of iron in each unit of packed red blood cells, so if you are going to transfuse somebody, know that you're giving them a large dose of iron. So how do we replace iron? I'm not going to go into this in too much detail because we're going to talk about it a lot in heme, but you can give it IV or orally. You actually calculate the amount of iron deficit that the patient has using this cool equation called the Ganzoni equation. That basically uses their hemoglobin, the target hemoglobin, and their weight to figure out how much iron they actually need. And then you actually divide that over time to make sure that you're appropriately administering the amount of iron that the patient needs. Don't memorize that. For any exam, I'll give you the equation. You just have to know how to use it. So advantages versus disadvantages. So if oral iron takes so long to absorb, why not just give IV iron? So they've actually done some recent studies that show, so previously the thought was the cost of giving IV iron is a lot more than giving oral iron because you have to have an infusion center that's going to infuse it. The cost of an IV infusion is more. You have to pay the nurse that's administering it. But actually when they've now looked at the comparison for the amount of time patients are on oral iron, the cost of the supplement, the amount of visits for follow-up hemoglobin and hematocrits, and the actual office time, the cost is approximately the same. And the IV iron works much faster. And actually I should say, it starts working approximately the same as what you would give for oral iron, but it's more efficacious, it works better. Because you actually absorb the iron directly into your systemic circulation versus having to go through first pass effect. First pass effect, the bioavailability is not great of iron. You can only absorb a very small amount of iron every day. So even if you're giving your patient like 500 milligrams of iron orally, they're only able to really absorb probably about like anywhere from a few milligrams to 10 milligrams a day maximum, which isn't much, right? So there is rare cases of anaphylaxis or severe allergic reactions with IV iron as well. And again, that has to be administered in an infusion center. Sometimes, depending on what the iron deficit is, sometimes one infusion, sometimes multiple infusions. So it's like a cost-benefit ratio. But what do you think the biggest inhibiting factor to being able to order IV iron for your patient is?
Does insurance cover it?
What's
Insurance?
that?
Does insurance cover it?
Insurance. Yeah, insurance doesn't want to cover it. Why not just trial oral iron? Right? Oh, they have to have failed oral iron for a year. Before you can give IV iron. So unless you can be creative in coming up with a reason of either the patient can't take the oral iron, but you really have to prove that you tried oral iron and it didn't work, which kind of sucks. Okay, so why not just transfuse everybody? Well, that's not a great option either because there's risks associated with blood transfusion, including some of the same risks we talked about, like cost, infusion center, nurse, all that stuff, in addition to the risks of actually giving a blood product transfusion is a problem as well. So there's many different formulations. There's really not one that's better than the other, but you want to make sure you know how much actual iron is in each formulation. The maximum amount of iron you can give in a day is 100 to 200 milligrams for adults and 3 to 6 mg per kg for kids. These are just some examples. So just knowing that the formulation does matter, because for ferrous sulfate, 325 milligram tablets actually has 65 milligrams of elemental iron in it. And ferrous gluconate, 320 milligram tablets, you think would be the same, actually only has 32 milligrams, about half as much actual elemental iron in the tablet itself. Only about 10 to 20% of that is actually even able to be absorbed. So what's the difference between heme iron and non-heme iron? So like think about a little less specific than that. What do I mean, like heme iron versus non-heme iron?
Bound to heme.
Yeah, so where do we find heme iron?
Bound to.
But in what products? Meat. Meat. Versus non-heme iron, green leafy vegetables, plants, right? So heme iron is the iron that we find in in animal products. That's actually much more better absorbed than plant iron, okay, non-heme iron. So who do you think is at risk for iron deficiency?
Vegans.
Vegans and vegetarians, right? People that don't eat don't eat meat products and only eat plant-based diets are at risk for iron deficiency as well. Okay. All right. I just included this so you can see some of the some of the types of iron that you can encourage your patient to take. So you do want to, when you order iron for your patient, it's mostly over the counter, so you want to make sure you tell them which formulation it is that you want them to get, right? Because some are going to obviously be easier than others to take. Slow iron or slow release iron tends to be a little bit less constipating, making sure that if your patient is having constipation, they either cut back on the dose or take a stool softener with their iron is important, and to make sure that they let you know. Because most patients stop taking their iron because of the constipation. They just stop it and then they never tell you. And then you're wondering, like, well, why is their reticulocyte count not going up? Why is their hemoglobin not going up? Well, that's why, right? Because they're so constipated that they stop taking it and they're not telling you. That's generally like 80% of patients on iron stop taking it. All right, so as Duyen informed us, taking it with vitamin C helps increase the absorption, but again, really only about 25 milligrams per day is really able to get absorbed, even with the addition of ascorbic acid. But it does help by chelating with the ferric iron at an acidic pH that the vitamin C helps maintain, and remain soluble all the way till you get down into the duodenum, which is really where the most of the iron is absorbed. All right, this is just a little table that tells you of what, how much iron really and how much of your daily value is in each thing. So there's certain things that are fortified with iron, but again, your meat products are gonna have really the most, even though you have fortified products with iron in it, it's non-heme iron. So the heme iron is really gonna be what is absorbed best. All right. So we know B12 and folate are essential for synthesis of DNA. So Tarika, what are those predominantly helping the cells do? Okay, good. So they help the cells divide. So if you're lacking B12, what do you think happens? So you have less B12. So what happens to your cells? They get bigger. Okay, what are those called? Okay, so megalocytes or macrocytes, right? Good. So what cells particularly get bigger? The red blood cells or the erythrocytes, right? What else happens?
They're fragile. They're not secure.
Good, good. What else happens to the other cells other than the red cells?
They're just not like multiply as quickly.
So if you have severe folate or B12 deficiency, you can actually have pancytopenia. You can, for sure. What happens to our neutrophils? Good, so the nucleus becomes not multi-nucleated, but the lobes, right? Actually, the patient develops hypersegmentation of the nucleus. Good. Okay. So they're really important for the building blocks of the cell and cell division, DNA synthesis. So there's going to be lack of cellular maturation and cell division for sure. And what we see, as you said, was large cells called macrocytes, which have a flimsy membrane, right? And actually are taken out of circulation early because of that. So this is an example of a hypersegmented neutrophil. These are examples of macrocytes, or large red cells. So who gets it? Obviously, there's different risk factors for each. So we see patients that have decreased absorption or lack of the ability to absorb either gastric bypass surgery, they can have gastropathy, autoimmune conditions. Remember that B12 is mostly absorbed in the ileum, and iron is mostly absorbed in the duodenum, and folate is mostly absorbed in the jejunum. You guys can review the list of who could be at risk. Kind of some interesting risk factors associated with B12 deficiency. Metformin. So in patients that chronically take metformin, there's been some studies that have shown that they have acquired B12 deficiency. A lot, I think that it's hard to really understand completely why. Although patients that have longstanding diabetes can have changes to the mucosa of the stomach and the intestine that decrease the ability to absorb B12 as well. So that may be why. But it's been compared to patients with diabetes that are on metformin versus patients that have diabetes on other medications, and the incidence of B12 deficiency is higher. Interesting. All right, so how do we treat? So there's two treatments available, either parenteral or oral. So what's the difference? So parenteral is injectable, right? Versus oral, obviously, is by mouth, right? So the parenteral therapy can either be given, actually 3 ways. So intramuscular sub-Q is probably the most common. It can be given IV, but that's really uncommonly used. So IM or subcutaneous injections or oral therapy. If you have a patient that's B12 deficient, the dosing schedule for B12 is frequent. So if you put them on oral B12, it's daily. If you put them in injections, they have to do it once a day for a week, once a week for 4 weeks, and then every month for maintenance. And it depends on if you're replacing somebody that's deficient for a reason, or like a reason that's reversible, or if they have some condition that is, they're never going to be able to absorb B12, like they had their ileum removed, right? Versus somebody that was maybe malnourished or had some other reason why they weren't absorbing B12, you can replace them and then take them off. So it's important to kind of try to understand the cause of the B12 deficiency to then determine how long you need to actually keep them on supplementation. Initially, the thought was that oral cobalamin therapy would not be as effective as IM or sub-Q because of the absorption, but the dose that we give is so high that we actually overcome the bioavailability issue, and you can actually give enough B12 orally that it's actually just as efficacious as IM or sub-Q B12. It is important though to follow up and make sure that your patient's responding if you're giving them oral. Especially because we're not, obviously there's different factors that are going to absorb absorption. My absorption might be different than yours, might be different than yours depending on our physiology, right? B12 is in foods, mostly in animal products. So patients that are vegan or vegetarian are definitely at risk for B12 deficiency. It takes a long time to become B12 deficient, but it can be a very detrimental condition. So does anyone know some symptoms or signs of B12 deficiency that are not present in other kinds of anemia?
Can have like neurologic signs.
Yes. So what kind of neurologic signs?
Just twitching? Twitches?
Not twitches. So it generally is numbness and tingling or paresthesias, and the stocking and glove distribution, so hands and feet. And that's actually due to a demyelination process that's happening in the spinal cord and brain. So you can actually see it on MRI of a patient with severe B12 deficiency. It is not reversible if it is not caught early enough. So it's very important that a patient that is already developing symptoms of numbness and tingling in the stocking glove distribution, I would be more predisposed to putting that patient on injectable B12 to be 100% sure that they're really getting the dose that's needed. Otherwise, they could have irreversible neurologic symptoms, right? And patients like sometimes have the inability to walk or like, write, hold things in their hands. It could be that severe. All right, so that is very concerning and needs to be treated right away. Folate deficiency usually is much more benign as far as symptoms that the patient's having. Mostly they present with anemia that's really asymptomatic. And we see folate deficiency fairly uncommonly, even though it's much easier to become folate deficient. Do you guys know why? Yes. So back in, I think it was the early 90s, what did we do? We added it to everything, right? We added it to all of our bread, our wheat products, our cereals, everything's fortified with folate. So it's like we really don't see folate deficiency in the US very often anymore because of that. Even though the stores of folate are much less in the body, and it's much easier to become folate deficiency than it is to become B12 deficient. But in patients that have alcoholism, they're at risk for both folate deficiency and B12 deficiency. That's probably the only patients that you'll really consistently see folate deficiency in. Yes?
So I know in all the breads they add back nutrients. Are those bad for you because it's not the best form probably? It's probably
Do you want to answer that question?
You heard it here first.
I honestly, the person to ask about nitty-gritty nutrition questions is the lady, down the hall from me. Yes, Morning. I think that you have to be very specific about what are you talking, what are you talking about that's being added. But for the most part, most of the stuff is naturally occurring things that we're trying to boost levels of in the body. So, Ashley says it's fine. A few words. All right. So remember, dietary folate is absorbed in the system. Can result in decreased dietary intake. I don't know why they don't fortify beer with folate, because that would probably eliminate a lot of our alcoholism folate deficiency. They should fortify alcohol and beer. Although I feel like that's kind of also encouraging the behavior, although it would eliminate a significant toxicity associated with alcoholism. Remember though, a lot of things can affect our ability to absorb medications. Autoimmune conditions like antibodies can affect our ability to absorb certain nutrients. I like this little mnemonic, I've had it up here now twice. So just helpful in helping you to remember where things are absorbed in the body. So who's at risk for folate deficiency? Like I said, we rarely see it, but when we do, it's often in alcoholics, elderly patients on a tea and toast diet that just aren't eating a lot of food that's nutritious, or they are only eating food that's pretty deficient in nutrients and not a lot of folate fortified bread, I guess. Vegans and vegetarians, patients with history of bariatric surgery or malnourished patients, and patients with chronic severe hemolytic anemia, pregnancy, and exfoliative dermatitis. What am I talking about? So you guys know what hemolytic anemia is. Learned about that. I think you know what pregnancy is. What's exfoliative dermatitis? Basically when you have some kind of rash that the skin turnover is rapid. So either a burn or some kind of inflammation of the skin. So the skin actually, healing and production of skin is very folate dependent. All right, so what happens in all of these conditions is that you're using up a lot of folate. Right, so chronic hemolytic anemia, why would you use up a lot of folate?
Make more.
To make more red blood cells, right? Because we know when we have chronic hemolytic or acute hemolytic anemia, the cells are being broken down rapidly, so the bone marrow has to produce cells rapidly, right, to try to keep up. So we see the reticulocyte count go really high in hemolytic anemia. Well, there's also, the folate stores are also being used up quickly. And so these are states where folate is needed in a more than what we can take in the body. Remember, the stores of folate we have are low. So in pregnancy, we tell moms to take extra folate. Why? Because there's a lot of folate being used to help in the development of the baby and the fetus, right? So in order to try to prevent, especially spinal abnormalities or malformations in the fetus, moms are encouraged to take a lot of folate, right? So any condition where you have rapid turnover of the red cells and you're asking the bone marrow to produce a lot, you have to ask yourself, does this patient need extra help, right? Need extra folate to be able to continue producing. These are the RDA requirements for folate. It's going to be a little bit different depending on if the woman is lactating pregnant or if it's an adult or child. These are some foods that are high in folate. So how do you treat folate deficiency? So treatment of folate deficiency is 200 micrograms per day. And I think I forgot to make the point that for iron and folate and B12 deficiency, you want to treat for a little bit longer than when you see normalization of the hemoglobin and hematocrit, because you want to make sure there's adequate stores, right? So you want to get their production up to normal, but then you want to give them a little extra so they're able to build up the stores so they don't just become deficient again, right? Because if you only give them enough to actually be producing but not to store anything, it's only going to be a matter of time before they rapidly become deficient again, right? Depending on which nutrient we're talking about. So treatment, so prevention. So in a patient that's at risk for folate deficiency, it's 200 micrograms a day. For a patient that's actually folate deficient, some studies will say 1, some will say up to 4 a day for several months until you completely reverse the anemia, and then for a little bit longer after that. All right, so let's just quickly get through granulocyte macrophage colony stimulating factor. So this is rarely used. We use a lot of granulocyte stimulating factor, but not a lot of granulocyte macrophage colony stimulating factor. They all really have the same mechanism, which is to stimulate the myeloid production and specifically granulocyte production. For GM-GCSF, though, if you remember back to this chart, remember that we're also getting stimulation of the megakaryocyte and erythroid line here, right? Versus GCSF, we're really getting stimulation mostly here. You get a little bit up here, but mostly here, right? And this is really the cells that we want to be produced when we're using this drug. So you can administer it either IV or sub-Q, and this, I've never actually used GM-GCSF in my practice, but I have used a lot of GCSF. So GCSF is either filgrastim or pegfilgrastim. So pegfilgrastim just is a different molecule that attaches the filgrastim to a long-acting pegylated form that allows it to last over a longer period of time. So Neupogen or filgrastim is a short-acting agent, right? We give it daily. The half-life is much shorter. Pegfilgrastim, we give it once a month, okay? And it sticks around for several weeks. So what do we use this for generally? So it's basically exogenous GCSF that we're wanting to stimulate the neutrophils. So can you guys think of a reason why we want to stimulate neutrophil production in clinical practice? So to fight off bad things.
So patient who has like chemo.
Great. So patients that are on chemotherapy, right, that are temporarily having their bone marrow suppressed, that we want to try to avoid infection. So we want to have their span or time of neutropenia as short as possible. We can give them these little boosts, right, injections to stimulate their bone marrow to try to recover faster and make neutrophils to decrease the risk, the time period where they're neutropenic and at risk for infections. So it decreases the risk of the duration and therefore the risk of infection in patients with malignancy who are getting chemotherapy. Also, we use it to mobilize. It actually goes into the bone marrow and cleaves the proteins that hold the hematopoetic stem cells into the bone marrow. allows them to go free in circulation so that we can actually apheresis them using a machine, pull them off, right, and then save the hematopoetic stem cells to use for stem cell transplant. That's how you do an allogeneic stem cell transplant. So you can actually give this drug, and then I could collect Emmy's stem cells, and if she was a match for Ashton, I could freeze those stem cells, and I could give them to Ashton later, and then they would come into Ashton's bone marrow with special preparation, sit down and make normal hematopoetic stem cells in the perfect world, right? And we do that. It's not as easy as I just made it sound, but we can do that. And this drug that was created really in the late 80s has really helped us to be able to do that, because before that we had to do bone marrow transplants actually using bone marrow, so harvesting somebody's bone marrow and then giving the bone marrow instead of being able to harvest peripheral blood stem cells. So how do you give it? It's weight-based. So there's the short-acting form and the long-acting form. What would be some risks of giving the long-acting form?
Is there, because it's so long acting, it would take a while to feed up the body, right?
Right, so what could happen?
So, overproduction. Like, yeah.
You say?
Oh, I don't know, I said overproduction.
I can't hear you.
I said overproduction.
Overproduction, yeah, so you can hyperstimulate the bone marrow, which can, I've had patients with white counts of 50,000. Okay, just give me just 1 minute to finish this thought. So white counts of 50,000, and they tend to have a lot of bone pain. So it's you can't take it back, right? Once you give it, it's there. Versus if you're giving it daily, you can check the CDC, how they're doing, or if they're recovered, then you don't give it, right? Versus when you give a long-acting form of any medication, just remember you can't take it back. So adverse effects, musculoskeletal pain is probably the #1 complaint of a lot of bone pain because it revs up the marrow to produce more cells. So pain in the long bones, so hips, femurs, arms, skull, sternum. I've had patients that have needed to be admitted to the hospital for pain control after getting these drugs. Pretty rare, but I would say it's pretty common for people to have musculoskeletal pain. Sometimes Claritin or loratadine, the anti-allergy medicine, can help with that for whatever reason. Leukocytosis, splenic rupture, so sometimes you can have so many white blood cells produced that the spleen's sequestering them, and I've actually had one patient that was a healthy donor who was receiving GCSF to stimulate his peripheral blood stem cells, who actually had a splenic rupture and had to go to the OR for a splenectomy. So it does happen. It's fairly rare. We also don't know the long-term complications of this drug because we've only had it around for 20 years. And then fevers are common too because it's inducing kind of an immune response. All right, and we will stop there for today. Happy voting.
Thank you.
We'll pick up on the 15th.
Blessed.